Good morning, everybody. My name is Dr. Ben Grafe, and today I'm going to talk about Parasomnias. Me and Alex go back a little ways, and he was my co-fellow when I was in training back in 2006, so it's an honor to be able to speak at the Wisconsin Sleep Society today. I'm going to stop the video and go to share screen here. And so Parasomnias is near and dear to my heart. I deal with it quite a bit at the VA where I work now. This meeting has been accredited by the ACCME through the AASM to provide credits for physicians. I have no conflicts of interest to disclose. Today we're going to talk about parasomnias by history and exam, how to utilize testing effectively, and become familiar with treatment strategies. By definition, this is a group of sleep disorders, abnormal, unpleasant motor, verbal, or behavioral events which occur during sleep or wake to sleep transitions. Classified as ICSD-3, Section 5, is non-REM and REM-related parasomnias, as well as other parasomnias. NREM parasomnias are recurrent episodes of incomplete awakenings, inappropriate or absent responses to others, no associated cognition or dreams, or partial or complete amnesia. And it's, of course, not explained by anything else, such as another disorder or substance use. Four main NREM parasomnias are confusional arousals, sleepwalking, sleep terrors, and sleep-related eating disorder. Features include a strong family pattern, so maybe dad had it or grandma. Typically onsets in childhood and fades into adulthood. Can be triggered by things like sleep deprivation, fever, illness, medications, and most of these occur in the first part of the night because that's when you're getting most of your stage 3 sleep, which is what these come out of. Generally, it doesn't reoccur in the same night. They tend to be long in duration, e.g. minutes as opposed to seconds. You can often have significant autonomic discharge, such as sweating, mydriasis, tachycardia, and tachypnea, and often you won't recall the event. Here's a little graph detailing that a little further. So about 20% of children, but less than that for adults. Sleepwalking is probably the most common of these disorders in this category. And then sleep terrors, which we'll talk a bit more. Generally a lot less as we go into adulthood. We have the 3P model, the predisposing, priming, and precipitating factors. Predisposing are your genetic relationships to others with this disorder. Priming include things like medications, alcohol, sleep deprivation, stress, and precipitating would be medical diagnoses such as OSA, PLMD, and noises. For confusional arousals, it has to meet the general criteria for NREM, as we just discussed. And they have to be characterized by mental confusion or confused behavior that occurs while the patient's in bed. Notably, there's an absence of terror or autonomic discharge or ambulation outside the bed. And this is what separates it from things such as night terrors. It's a dissociated state in which sleep patterns in cortical areas can be accompanied by wake patterns in others. It's a wide cortical network, includes the hippocampus, and altered consciousness may be due to inferior frontal gyrus activity. This is a video example. So you can see that there's no autonomic discharge, just literally sort of a confusional, like what's going on sort of scenario in a child. But you can see that the EEG shows that the child is sleeping. Sleepwalking has two criteria. It has to meet the general criteria for NREM and not associated with, is associated with ambulation and other complex behaviors. In fact, they can do most things they can do while awake. Things like turning, playing with the sheets, sitting up. In children, of course, and adults, you can do things. I've had people that attempt to drive a car or leave the house or walk around the front of their house. People that work at hotels often see this. It's kind of an inside sort of knowledge thing where they see people sleepwalking between rooms at night and they have plans on how to deal with people. It's an altered state of consciousness, impaired judgment, person's generally calm. There is some degree of safety risk, which we'll get to. Here's an example of a gentleman in an ER. It's probably late at night during your medical residency. The treatment for this involves finding the underlying cause, and usually something precipitates it. Sleep deprivation, apneic events, leg movements, and we don't often treat this with medications because if we can find the underlying cause, we can save the side effects from a medication. Sexsomnia is a variant of parasomnia. I presume that most people here may not have seen this. I had heard about it for many years, but I did see a few cases at the VA, which was interesting and pretty striking when you see it. It's tied in with confusion, arousal, sleepwalking, generally in bed, males more than females. It involves sex, as you might presume. And there's no recall of events, which is certainly troubling to the patient, but definitely to the spouse as well. Can have some legal and social consequences. I had a patient, in fact, that he was doing these things in his bedroom, but he also had children. And then if the children came in to sleep with the parents, it caused some significant problems. And they ended up having to lock the door and do all kinds of safety measures to make sure that this wouldn't occur anymore. So it causes some odd interactions. Sleep terrors, as we mentioned earlier, you get this discharge of activity. You can have alarming vocalizations, tachypnea, tachycardia, mydriasis. Still has to fit the general criteria for an NREM disorder. It's going to be earlier in the night, can be longer in duration. The child may appear to be alert, which confuses parents, and he may not recognize them. They may have their eyes open. Generally, consolation doesn't seem to be effective because the patient's actually sleeping. And after a while, what will happen is they'll relax and fall back asleep. But it's certainly concerning to the parents and bothersome to the parents, and they're worried that something's wrong with their child, especially when someone's screaming in the middle of the night. There's this thought that there might be a threat or danger. Treatment of these night terrors is you want to treat the underlying condition, address stress in the child. Sometimes they use this technique called anticipatory awakening, where the person wakes 15 minutes before they typically have an event and then stays awake for a few minutes before falling asleep again. And there are some medications, but in children, often these are not used. Benzos may be helpful, or antidepressants if a med is needed. Sleep-related eating disorder came on the scene in the mid-90s, I would say. Recurrent dysfunctional eating occurring during the sleep period. And it's associated with eating peculiar combinations of food or toxic substances, sometimes inedible foods, think like maybe pica. Sometimes these people can injure themselves while preparing the food, which can always be an issue. And then there's adverse health consequences from recurrent nocturnal eating. I had a patient once that ate an entire box of Texas toast that was in the fridge for the Sam's Club size. And they came downstairs the next day and were quite frightened that someone had broken into their house and reached in their fridge and eaten all of their Texas toast, and there were crumbs everywhere. And so it causes the patient some distress in the morning, because not only was it they who did it, but they don't really understand that no one really broke into their house and left this mess, and they also gained the weight as a factor. As noted, there's minimal recall, and it's not explained by another sleep disorder, mental disorder, medical disorder, medication, or substance use. Can be tied into restless leg, PLMD, sleep apnea, as many of these disorders are. Also mental health disorders such as depression, bipolar, anxiety, and some medications can have this effect. In fact, if you see those medications, it's worth a shot to withdraw them, especially if the sleep-related eating is new in onset. I think sometimes people jump to a conclusion, but it may be medication related, so always consider that as a possibility. Here's a video on sleep-related eating disorder. Get it to play here. So fortunately, she was able to seek treatment and did well. So for treatment, for all of you out there, safeguarding the environment, you don't want them tripping over things or dealing with sharp things, knives, sometimes even forks or hot objects. Rule out other comorbidities or triggers. Consider pharmacologic treatment. SSRIs are probably the most commonly used if a medication is used. Also topiramate and clonazepam. Non-pharmacologic includes sleep extension. Sleep disorder that is most common is insufficient sleep, so something to always think about. Avoiding alcohol, cannabis, and other meds. Watch their sleep-wake cycle. Maybe they're getting enough sleep, but they're varying it throughout the course of the week, or maybe they have a job that's a shift work. And educate the family as well as the patient. So let's change over to REM parasomnia. So we just completed the non-REM side. Let's talk about the REM side. So REM, going to be later in the day, sorry, late in the evening, into the early morning. We generally get deep sleep the first part of the night, then we trend toward REM stage sleep later on. This is also when you're going to see sleep paralysis and nightmare disorders. REM behavior disorder, which it was interesting to me. I saw was originally sort of coined or officially diagnosed by Schenck in 1986, which doesn't seem that long ago. Of course, if you're younger than me, maybe it seems like a long time ago, but for us 80s kids, that does not seem that long ago before these people finally got treatment. You think about all the patients and veterans through history that were pre-86 that probably had this. Repeated episodes of sleep-related vocalizations, complex motor behaviors, documented by polysomnography or based on clinical history of dream enactment presumed to occur during REM sleep. And that's an important note there. You know, before I joined on to VA, we generally did sleep studies on all of these people before we treated them. And that makes sense in the right practice environment, but I see it a lot at the VA. And it really kind of comes down to significant history. So if you have somebody acting out dreams, punching their spouse, punching holes in the wall, jumping out of bed, you can't often wait 3 to 6 months for a sleep study and then hope that something happens during the sleep study. You want to keep that patient safe. So use clinical judgment when there's severity involved, and it may not be the best option to wait for a sleep study, especially if you have a delay. If you do get the sleep study, you'll see REM sleep without atonia, and it's not better explained by another sleep disorder or mental disorder, medication, etc. Here's what you'll see on PSG. You'll see REM sleep without atonia. It's fairly rare, like 1% at the most of the general population, mostly older adults, men, 60s and 70s. It's less common in the younger. It can have associations with narcolepsy and Huntington's disease, and do think veterans. I can't stress that enough because it's, I see it at least 10 times as much now as I did when I was in private practice. Complications that can lead to things: Parkinson's, Lewy body dementia, MSA, and 80 to 90% can convert to a neurologic disorder, which is quite high. So you go through this whole thing where you explain it to the people that you finally figured out what's going on, and then you tell them, by the way, like, this is a precursor to another really bad neurologic complication. So it's always a very hard conversation. So don't just stop at making the initial diagnosis. It can predate these by a decade or more. Here's a breakdown of prevalence of RBD and the different alpha-synucleinopathies. You can see MSA is quite high, Parkinson's, Lewy body dementia, and you can see the delay in onset in the number of years. I know there was one veteran I had seen that had been having RBD for a while, and so I like to ask certain questions about how they're doing, or whether they have a tremor or shuffling gait, or problems with articulate movements. And one of the ones I always ask is whether they can put sugar in their coffee or their tea. And one of the veterans I was talking to, he already had some sort of movement disorder, because he said over the last few years he had a very hard time trying to get sugar into the cup. So here you're dealing with a very late diagnosis of RBD, and now it's already progressing to some sort of movement disorder. Meds that can be used include SSRIs, SNRIs, tricyclics, MAOIs, mirtazapine, and also think about withdrawal from substances that can precipitate, such as alcohol, benzos, barbiturates. If you recall back in med school and maybe in your fellowship training, all these key neurotransmitters: ACH, GABA, glutamine, histamine, noradrenaline, orexin, melanin, and all the different tracks and how they affect the brain throughout the sleep cycle. I won't touch you on this, but if you remember the initial model of the CAT model, where they were able to induce REM behavior disorder, that's probably the most common referenced research article. Here's a video of REM behavior disorder. See the patient becoming a little bit more active now. And if you've done sleep long enough, you've certainly had good examples of REM behavior disorder and seen patients act out their dreams in the sleep lab. Treatment, of course, safeguard the environment. Maybe that means putting the bed closer to the ground, getting sharp objects, sharp corners of beds or dressers or file cabinets away from the bed, trip hazards, anything that could injure the patient. We talk about firearms in the VA, certainly. Watch out for the spouse, sometimes sleeping in a separate bedroom. And the medications are going to be melatonin and clonazepam. It seems to kind of come and go with the tide. For a while there, melatonin was in vogue and recommended as a primary, but it seems to have shifted back to clonazepam. Personally, for patients that are acting out pretty severely, punching, kicking, jumping, falling out of bed on a nightly basis, I'll go directly to clonazepam. It tends to be better at blocking motor activity. For milder cases, I will try melatonin first and titrate up to 5 to 10 milligrams, but it's sort of a judgment call. But overall, I think the clonazepam is stronger. I think most of you probably agree with that. Screen for neurologic symptoms, get them in the hands of neurology, follow up quickly after starting meds. So what I like to do is I'll bring these people back in 2 weeks, and I realize you guys are busy and you may not be able to do that, but I like to know right away whether we're working. I don't like to put them out there with a 0.5 milligram and, see if it works and come back in 2 months. I like them to get good therapy, good resolution, and then talk about their prognosis. Another thing I'll mention is in the VA, there's been a lot of people suffering with morbidity and mortality from RBD. And surprisingly, there's still a fair amount of PCPs that don't ask about this. And so if I could pass on one thing to you is if you have veteran patients, at least consider it and maybe even educate them on it, because they may have a friend or a father or somebody else that develops this. The gentleman I took care of in the last couple of months had suffered with RBD for 20 years, had bounced around to different primary care doctors and psychiatrists, and never really got treated. He got put on lots of different antipsychotics and antidepressants and suffered and suffered. And when he finally got into my office and I told him what was going on, he literally broke down in tears because he finally had somebody tell him what was going on. He literally thought that he was going crazy because he just wasn't speaking the same language as his providers. And now that he's on treatment, his life has changed significantly. He sleeps well through the night. He shares the bed with his wife again. He's functional. He's being seen by neuro. So it's really unnecessary that he had to suffer so long. And so I had one PSA that you take away from this is try to educate primary care doctors on the possibility of this so that they don't end up suffering for so long. Sleep paralysis, I'd venture to say many of us have had this, especially as residents. Hypnagogic is when you're falling asleep, and hypnopompic is on awakening. Rematonia, persistent to wakefulness. You can have auditory, tactile, or visual hallucinations, sometimes not at the same time, sometimes concurrently. If you remember, like after a long 30-hour call, you may hear things aren't there or see things that aren't there. It's just the brain kind of in a sleep-deprived state. 7.6% of the general population's had at least one episode. It's also higher in students and psychiatric patients. Associated conditions can be things like hypertension, hypersomnia, insufficient sleep, which is the most common. Of course, narcolepsy, it's part of the tetrad, sleep apnea, alcohol use, and Wilson's disease. Treating the underlying condition is paramount. Reassurance. A lot of people once they have this, they feel like they're going to develop some sort of weird neurologic disorder or Lou Gehrig's disease or something. And so you really have to talk to them about sleep extension and how this may not come back if it's properly addressed. And there's also sometimes used for SSRI, but I would say generally this is not a medication treated disorder. Nightmare disorder is occurrence of extended, dysphoric, well-remembered dreams, threats to survival, security, or physical integrity. From these dreams, people rapidly become oriented and alert. They cause significant distress, impairment in social, occupational, other areas of functioning. Here's the famous Fuseli, the nightmare painting. So you see the mare in the corner there and the demon sitting on the woman's chest. Nightmare disorder affects 4% of adults, has an impact on quality of life. It can result in avoiding the bedroom. I have patients that had fear of sleep and they'll try to stay up all night until the sun rises, if they are fortunate enough to be able to do that with their work schedule. Or they'll sleep in another bedroom, or they'll just curtail their sleep. Can be tied to psychiatric illness, and of course has all kinds of impacts on sleep quality, insomnia, daytime sleepiness. Things like CBT can be used for PTSD related, exposure, relaxation, dream rehearsal therapy. Dream rehearsal therapy, if you recall, is writing out the nightmare and crossing out the parts that you don't like and changing them. I like to have them change to either silly things or humorous things. You know, I had a guy who was in the Korean War and he was being asked for his papers and then chased down and shot at. And so we'll scratch out those parts and he'll talk about, you know, while he was chasing him down, he wanted to give him something. He had a balloon animal or water balloons he was throwing at them. So that it nullifies the nightmare for them. You know, it can be silly. This is not about being factually correct. This is about trying to nullify the negativity of the dream so that the veteran can sleep again, or the patient. Non-PTSD related hypnosis, lucid dreaming, muscle relaxation, desensitization. These are all helpful. There are medications that can be used, and there's a laundry list of them here, but the one that has the most support is prazosin. That's the one we use in the VA. It's also come in and out of vogue, and there's been some articles that don't support it. But in a recent 2020 analysis, meta-analysis, that did show support for prazosin as being the most helpful. Start at 1 milligram and titrate upwards. I've seen recommended use 3 to 16 milligrams. I would say by 4 or 5 milligrams, you should definitely be getting some effect and it should be helping. Other parasomnias, less common in adults: exploding head syndrome, sleep-related hallucinations, sleep enuresis, and then other ones due to medical disorders, substances, etc. Exploding head syndrome is something I've never really seen. Ironically, the only person I've ever seen that had it was my own medical director. He's in his 40s and he had it one time. So it's not really fully well understood. Essentially, you feel like your head's exploding when you wake up. It's painless, as opposed to, say, migraines or subarachnoid hemorrhage, but something to consider in the differential, certainly. Reassurance, relaxation, and then weak evidence for benzos, TCAs, etc. I guess it just really depends on how often you're having it and how bothersome it is. Certainly the one that my director had was not clear in pattern and occurred as a one-off. So you hate to start something like that for something that occurs almost never. Nocturnal frontal lobe epilepsy is always in the differential, so you want to consider that for parasomnias, especially if you see repetitive behaviors, lip smacking, fidgeting, picking, fumbling, etc. These are seizures that occur exclusively or predominantly in sleep. They can be benign, they can be familial, and you may want to get neuro involved. You know, if you are in neurology, that's great. You can continue to handle it. You know, for a lot of us that are either IM, pulmonary, or ENT, this gets out of our range, but you want to have neurology involved with these people. Here's a video on nocturnal frontal lobe epilepsy. So you can see where there'd be some crossover there with night terrors, if you didn't have that EEG. So something to kind of use to compare and contrast. There was a little bit of repetitive movement there with her legs for a moment there too, but just something to put in the differential as a possibility. All right, so summarize all of what we said today. These are abnormal behaviors that occur during sleep or wake-sleep transition. Main two categories are REM-related and non-REM related. You can use that to formulate your differential, to determine what time of day it's happening, how long it's happening. Think about sleep, sleep duration, medication, sleep time, substances, and psychiatric comorbidities. Remove offending agents. Talk about a patient lifestyle, sleep schedule. Treat things such as sleep apnea, PLMDs, etc. And sleep extension is always a good idea. Like I said, that's the most common sleep disorder. If you ask people when they're going to bed and when they're waking up and they're actually trying to sleep, not just to watch TV, it seems like everybody is short on sleep. So think about that as a possibility. And there are people that are long sleepers as well, as you know. Safeguard the sleep environment, pharmacotherapy if needed, but generally not the first recommendation. I want to thank you again for listening today and for the opportunity to speak with everybody. I hope this helps everybody out. If you have any questions, I'm sure my email will be posted and I'll be happy to help everybody. Thanks also to Alex for assisting in this PowerPoint today. I'm in a bit of a job transition and there's a lot of moving pieces, but Alex was very helpful. Thanks all and have a good week.